From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to our listeners around the world. You're listening to the JAMA Clinical Reviews podcast. Thanks for being here. I am Dr. David Simel, JAMA Associate Editor and Professor Emeritus of Medicine at the Durham Veterans Affairs Medical Center and Duke University. In this podcast, we will be discussing adult survivors of congenital heart disease. I'm joined today by Dr. Mike Landzberg, who is the immediate past director of the Boston Adult Congenital Heart Group between Brigham and Women's Hospital and Boston Children's Hospital. Dr. Landzberg is the senior author of our narrative review on this topic, which appears in the June 8, 2026 edition of JAMA. Dr. Landzberg, thank you for joining us today.
Well, Dr. Simel, first and foremost, thank you and the editorial board, and perhaps most importantly, the audience of JAMA.
Well, why is the topic of adult survivors of congenital heart disease relevant to generalist physicians?
If we look across the globe, about 1% of all live births are infants with congenital heart disease, born with heart disease. Now, if we break that down to the subgroup of adults who are born as so-called blue babies, we're talking about 1/5 of that, about 0.2% of all live births. In our patient populations that we see as general practitioners, internists, all care providers, you're going to be seeing survivors who are born with cyanotic heart disease.
Well, you reviewed three common situations, relatively common in terms of the cyanotic congenital heart disease spectra, and that was tetralogy of Fallot, D-loop transposition of the great arteries, and single ventricle Fontan circulation. So let's talk about each of these, starting with tetralogy of Fallot. Can you explain the anatomy of tetralogy before it's repaired?
David, a pleasure. Let's briefly talk about what that means, how we came to adult survivorship, and the issues that these young and older adults now face. Tetralogy. By definition, when we were in nursing school, medical school, general physiology, we remembered that tetralogy were four things. I'm going to suggest that we remember them as one thing, monology, if you will. The key issue is that a bulk of tissue is displaced, is malpositioned. And that bulk of tissue sat in the ventricular septum, and it gets pushed up away from the wall between the left and the right ventricles into the budding tree or the outflow from the right ventricle called the pulmonary artery. That bulk of tissue, which is malpositioned, causes pulmonary stenosis. Right next to the pulmonary stenosis, the pulmonary artery itself grows in an hourglass shape that causes hypoplasia, or relative narrowing there. As that bulk of tissue got moved away from the ventricular septum, it left behind a hole called a ventricular septal defect. The ramifications of pulmonary stenosis, we remember that in our schooling, that if there is stenosis to the outflow of a ventricle, it develops concentric hypertrophy. So right ventricular hypertrophy is part of that tetralogy. And the last thing is an anatomic variation. If this bulk of tissue is sitting in the outflow tract, it acts like a bit of a seesaw. On one end is the bulk of tissue. On the other end is the aortic annulus. If one gets pushed in one direction, the other gets pushed in the other direction. We have overriding of the aortic annulus. The big key things for us, though, is the stenosis to the pulmonary artery and the ventricular septal defect. Blood is a simple fluid. It likes to take the pathway of least resistance, David. And because of that, if there is obstruction to the outflow from the right ventricle, the blood may pass instead of going to the lungs directly from the right ventricle to the left ventricle. And cyanotic blood, oxygen-deprived blood, not filtered by the lungs, makes its way to the systemic circulation, and kids are blue.
So is the main problem the right to left shunt that causes cyanosis?
Yes, on the surface, these kids are blue and they are cyanotic. But the issues are so much more. As you could imagine, the right ventricle is pressurized. And because of that, in its future, no matter how we repair it, it's going to feel the latent effects of increased loading conditions. The fix is relatively simple on the surface. We go inside the heart via the pulmonary artery or the atrium, and we remove the bulk of tissue. We put a patch over the hole between the two ventricles. And that hourglass, which was the trunk of the pulmonary arteries, we create a gusset or a patch, and we patch over it. The downside of all that is that narrowing was right where the pulmonary valve was. And most frequently, what we're doing is we're destroying the effectiveness of the pulmonary valve and creating a scenario where almost all children come out of this operation that relieves the obstruction, closes the hole, but leaves them with pulmonary regurgitation. On one hand, we took a disease that left 20% of all children alive at 10 years, 80% mortality at 10 years, and we created a scenario where, in fact, 80% of adults with tetralogy of Fallot are alive at 40 to 50 years and doing well. That's a huge change. The kicker is that there are lots of issues that are left behind because of that initial physiology and pathology that these children faced and adults now face. We talked about the pulmonary valve being left as regurgitant. You can imagine most of us, when we deal with regurgitant valve lesions, we think about immediate issues, aortic regurgitation, mitral regurgitation, and the effects of that. The beauty of the right side of the heart and the pulmonary valve is that when we talk about the effects of a leaky valve, we look at the balance between the resistance or the obstruction to flow through one area, namely the resistance of the lungs or the impedance of the lungs, versus the backflow and the ability for the right ventricle to tolerate that flow. Whereas aortic regurgitation is not tolerated well over a lengthy piece of time, pulmonary regurgitation is tolerated quite well for decades. And so that it's not at all uncommon that kids survive 2, 3+ decades before we have to consider intervention on their pulmonary valve. Well, the effect of a leaky semilunar or pulmonary valve is one where the right ventricle becomes volume loaded. And a volume loaded ventricle attains eccentric hypertrophy. It dilates. And as it dilates, a number of things happen. Over time, that ventricle becomes less efficient. We have less ability to meet the demands of our body. We become more fatigued. We have less functional capacity. The right ventricle responds by retaining volume. We become suffused. We develop edema, ascites, lower extremity edema, and our organs become saturated with extra volume. The right ventricle is a structure that has a deep tie between its electrical function and its mechanical function. And so that as the right ventricle becomes less efficient, it also develops more and more arrhythmia. About 20% of adults who have tetralogy of Fallot will face atrial arrhythmias, most typically atrial tachycardia, by the time they're in their 40s and 50s. And about 1% per year of adults with tetralogy will face either sudden cardiac death, aborted sudden cardiac death, or sustained ventricular tachycardia, most typically from monomorphic ventricular tachycardia every year. Thankfully, most of that ventricular tachycardia is approachable in the electrophysiologic lab by ablation, and most of those atrial tachycardias are similarly treated by ablative techniques.
Well, let's talk now about transposition. How are those children born, and what is the fix for them?
Transposition of the great arteries used to be a disease in which perhaps at most 20% of children survived 1 month of age. And now, in fact, 95% of affected individuals survive 45, 50 years. What a huge miracle of the advances of medicine. Typically, as you know, in each of us, the aorta is a posterior structure over the posterior left ventricle. It's on the left side, and the pulmonary artery is on the right side and anterior. Transposition, as the two great arteries are forming, involves the shift more anteriorly and oftentimes rightward of the aorta, and posteriorly and oftentimes leftward for the pulmonary artery. What that means is the right atrium connects to the right ventricle, but the right ventricle now connects to the aorta, not the pulmonary artery. The left atrium connects to the left ventricle connects to the pulmonary artery, not the aorta. Things are switched. And what happens is that blue blood stays blue, red blood stays red. We have two ineffective circulations that are in parallel and they're not mixing. And the only way that these children survive is by either naturally created connections inside the heart or the blood vessels, or mechanically created connections, us as clinicians creating holes inside the heart to stabilize that circulation, and ultimately surgically for us to correct and re-switch what children were born with, so that we put the aorta back on top of the left ventricle and the pulmonary artery back on top of the right ventricle. Just a short historical note, we weren't able to do that for decades, and because we couldn't fix the outflow of the heart, we learned ways to so-called MacGyver, and we fixed the inflow of the heart, so-called atrial switch operations, which carried a major success, but much less so than the more modern arterial switch operations. To be fair, in this modern era with an arterial switch operation, we face concerns that relate to the surgery itself. We're moving two very large structures, the pulmonary arteries, and we're moving the aorta. Scar tissue forms every time we create surgical sutures. We do extremely well in terms of separating the coronary arteries, moving other structures, and putting the coronary arteries back, attaching them to the aorta separately. We create so-called buttons, and we move them. The problem is that we don't always do it in a fashion that's perfect, and about 10%, yes, 10% of adult survivors with arterial switch operation have had silent narrowings, myocardial infarctions, but live well with them. And mostly that occurs in youth. And by the time there are adult survivors with this, coronary arteries are almost always patent, or they are compensated in their relative narrowings.
Well, let's move on to the single ventricle that requires stage surgery that ultimately ends with the Fontan circulation. Could you describe that for our listeners?
Patients with single ventricles are the least frequent, at least at the present time, in the practices of many internists, general practitioners, and subspecialists. By definition, a single ventricle, and those are the diseases you may have heard of as hypoplastic left heart syndrome, tricuspid atresia, double inlet left or right ventricle, whatever those names are, they batch themselves into a physiology and anatomy that we call single ventricle. In essence, blue blood and red blood enter in from our systemic veins or our pulmonary circuit directly into one common ventricle. And you can imagine the issue there is that this one ventricle handles two loads of volume. It becomes eccentrically hypertrophy, dilated, and it has to allow blood to mix and go to both the lungs and to the aorta. We need to separate the blue from the red, allow less volume into that one ventricle, but distribute the blood beautifully to the lungs and to the body. This gets done in a staged fashion, typically in the neonatal time. Congenital cardiac surgeons create some means of controlling the blood flow to the lungs. By the time kids are somewhat in the order of 6 to 9 months, they will undergo a first surgery or a second surgery where we call this effective pulmonary blood flow. The venous blood flow from the superior vena cava is directed to the lungs. And then it's somewhere between 18 to 36 months, we perform the surgery called the Fontan surgery, where the inferior vena cava is connected along with the superior vena cava directly to the lungs. and we have a completion of a separation between blue and red. All of the blue returning blood from the systemic veins goes directly to the lungs, and the rest of the heart handles the red blood coming back from the pulmonary veins. The issue here, as you could almost hear from my discussion, is that there's no pump to the lungs, and the circulation mandates that the effective pumping of the one ventricle that is pushing blood out to the body and the functioning atrium, which is adding a kick to that blood into the ventricle, needs to literally suck and allow the passage of blood through the lungs and across the systemic veins to the lungs in a very efficient fashion. Beautifully, these kids who were not surviving neonatal times now survive at 50, 60% survival well into their 40s and 50s. The consequence, though, is that blood likes to flow downhill. And usually in you and me, we have a pump that pushes blood up to the lungs, to the pressure of the lungs from our systemic veins. There's no pump here to the lungs. And so our systemic veins live, if you will, at a higher pressure. And that higher pressure has consequences. That higher pressure has consequences because it creates more tension and more inflammation throughout the entire body, on our viscera, on our liver, on our kidneys. It causes increased hydrostatic pressure, more edema, ascites throughout the body. It creates higher pressure in the lymphatic system. So that means we have lymphatic leak in some patients into their gut, so-called protein-losing enteropathy. It creates lymphatic drainage into the lungs, so-called plastic bronchitis. And that higher venous pressure also creates disease in our systemic veins. We develop engorgement and enlargement and venous disease, all of which creates a scenario for greater inflammation and greater long-term morbidity and consequences of that. By 15 to 30 years after the Fontan operation, some 40% of adults face a failure of this circulation, the inability of the human body to keep up with its demands. And failure of the Fontan circulation isn't just about, hey, the heart isn't pumping efficiently, or hey, the heart is too stiff, heart failure with preserved ejection fraction, or heart failure with reduced ejection fraction. It's also a failure of the many organs that are seeing the consequences of increased venous pressure, increased inflammation, and ultimate dysfunction. Liver disease, for example, a hepatic dysfunction, becomes almost the rule in a compensated fashion in most adults with Fontan circulation by about 15 to 20 years after their surgery. Some of those consequences of inflammation is the development of hepatocellular carcinoma, which all adults after single ventricle repair or Fontan repair are screened for every 6 to 12 months. Hepatic disease, renal disease are all highly prevalent, which brings me to a point that I'd like to review for all three of the disease entities that we discussed before. Adults with cyanotic congenital heart disease, David, are very much 20 to 40 years older than their chronologic age when it comes to medical comorbidities. What do I mean? If I have an adult who's 20 to 30 years old with either tetralogy, transposition of the great arteries, or a single ventricle, their risk of heart failure, their risk of atrial arrhythmia, their risk of ventricular arrhythmia, their risk of sudden cardiac death, their risk of stroke, cerebrovascular disease, renovascular disease, other comorbidities approximates that of somebody who's 50 or 60 years old.
Well, Mike, your enthusiasm for these conditions and the care of these patients is refreshingly palpable. At the same time, I've got to imagine this is terrifying for parents and for the children. And I'm wondering if you could address the psychosocial issues of the child growing up into adulthood with congenital heart disease.
Wow. Dr. Simel, you raise a point that comes back in so many ways between the distinction between computerized or artificial intelligence as a guide to medical care versus a clinician in terms of how we see our patients and understanding our patients and seeing the multiple facets of suffering in their lives. All of these kids, now that they are adults, have faced multiple surgeries, multiple interventions. And I would say to you, almost no one in our care has not faced trauma in one form or another, trauma to physical aspects of their lives, multiple medicalizations, trauma to their hopes and values of who they are inside their life, their role in society, their role in their families. The prevalence of depression and anxiety are considerably higher in this population as contrasted to age-matched controls. The prevalence of abnormalities of executive dysfunction, how these young adults face and understand the world about them is considerably different because of their early neonatal or early in life surgeries and cognitive changes that have occurred because of cardiopulmonary bypass. Now that I say that, I'm astounded by how normal all of our patients are and how functional they are. Are they functioning against a threat? Sure they are. But we have patients that are well known to our audience who are Olympians, who are major CEOs of companies, educators, professionals. And at the same time, if we want to be complete clinicians to them, our awareness of the many facets of what goes into functioning well helps us and is perhaps a perfect lead to one clear statement. When we look at why kids have survived well into their adult years, we don't have data to say that it's the cardiologists or the cardiac surgeons who have made this happen. The answer that we've consistently found is that it's coordinated care at large comprehensive medical centers that engage in all consultants, primary physicians, internists, and support staff who together have allowed for well-being and continued survival. We have not been able to pinpoint that it's a singular aspect of that entire comprehensive unit.
Well, I am Dr. David Simel, and I've been speaking with Dr. Mike Landzberg about survivors of cyanotic congenital heart disease. You can find a link to the article in this episode's description. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcast. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.